Welcome to the show discussing problems and issues of health with Dr. Alcena. For this segment of the show, I'm going to begin a series on cancer of the stomach. Cancer of the stomach is an extremely difficult cancer to cure. This year, according to the American Cancer Society, 28,000 folks in this country will be diagnosed with cancer of the stomach. And of that number, 10,960 people would die of cancer of the stomach. Now, worldwide, roughly 750,000 people will be diagnosed with cancer of the stomach, and 736,000 of them will die of the cancer of the stomach. Cancer of the stomach is 2 or 3 times more common in black folks as compared to white, and the death rate is similarly disproportionate in terms of white versus black. Now, the risk factors for cancer of the stomach is a very interesting thing to see. First of all, you have the genetic component of it. You have environmental component. Smoked fish, people who eat a lot of smoked fish in countries where a lot of smoked fish are eaten, those folks have a high incidence of cancer of the stomach. Processed food, and people who are infected with H. pylori infection, smoking, alcohol abuse, obesity, etc. Now, there are countries that are much more associated with high incidence of cancer of the stomach, such as Japan, for instance, Finland, and all the Scandinavian countries, wherever people love the concept of eating carbonated type food that are cooked on the outside carbon type thing, and the action of the carbon burning process create a burning thing that is basically carcinogenic. And the world over, there are more cancer of the stomach in Japan than proportionately than any other place. This is a very common cancer there. And another problem that one has to keep in mind is the H. pylori infection. H. pylori infection is the most common infection associated with people-to-people transmission across the world. 50% of the world population are infected with H. pylori infection. New York City is much more common. Some 70% of people are infected with H. pylori because you have people from all over the world. And the countrywide in the U.S., some 35% folks are infected with H. pylori infection. It's a nosocomial type infection because once it is in the household, people use the same bathroom. No matter how clean they are, no matter how hygienic they are, it is very easy for contamination to occur. As a result of that, that's one of the reasons why it is so common. And in developing world, of course, the sanitation leaves a lot to be desired because it's poor sanitation, and people don't always have access to soap and stuff they could wash their hand after they have bowel movement, etc. Because this particular infection is fetally transmitted. It is transmitted from fecal contaminated food or water that people either drink or eat. That's how it gets transmitted. And the H. pylori infection is known to be one of the causes of cancer of the stomach. In particular, there's a special form of lymphoma that can develop because of it as well. And H. pylori, of course, can cause a whole host of other stuff, a whole host of other problems. This particular book, The Art and Practice of Modern Clinical Medicine, that I wrote last year, is a big chapter on H. pylori and on all the different things, how to go about diagnosing it, etc. But I'm mentioning it here because you can't talk about cancer of the stomach without mentioning H. pylori, because each time the gastroenterologist will do an endoscopy, they must, by convention now, do H. pylori testing, because you could have that infection and don't know that you have it. So now it is a common practice that when they do an there are several ways, by the way, of diagnosing. You could do a blood test, you could do the breathing test, you could also do the stool test, But the easiest way, the two easiest ways, one is the blood test, that's very easy. The other one is when they do a endoscopy. They have two ways of doing it. They can actually take gastric juice and put a substance, put a things on it and see what color it turns. And they can also take the biopsy. And the biopsy then gets sent to the pathologist. They have special staining they do looking for H. pylori, so on and so forth. So now let's talk a little bit about the symptoms of cancer of the stomach. The list is quite long. Recurrent indigestion, recurrent heartburn, which is so common. Heartburn, also known as GERD, is common in most people over 60 years old. Close to 50, 60, 70% of people 60 or older suffer from GERD. Very common. Recurrent nausea and vomiting, diarrhea or constipation, bloating, upper stomach pain, weight loss, anemia, poor appetite, fatigue, vomiting blood, black tarry stool. Okay, now, here's the thing. There are many things that one can pick up early on that can lead one to diagnose cancer of the stomach very early, making it easier to treat. Again, I'm going to go right back again, talk about the anemia part of it. And the reason, because all these other symptoms that I just mentioned, by the time you start feeling them, the cancer probably has already grown to a significant size. However, you can't have cancer of the stomach without bleeding, even though you don't see the blood, without having iron deficiency. You have to understand, iron deficiency is not the same as iron deficiency anemia. Now, for teaching purposes, it's very important to understand what iron deficiency is. There's a long chapter in this book on iron deficiency that shows you the different steps of iron deficiency that ultimately lead to iron deficiency anemia. This concept is called iron kinetics. Now, if one understands that way before you start having abdominal pain, indigestion, bloating, etc., the suspicion that something is going on. Let's take example of a man. I talked about that last week with cancer of the esophagus. I have to repeat it again because we have iron in the blood in the red blood cell that are circulating, and we have iron that is in the storage. The iron that's in storage is the ferritin. As I mentioned last week, the ferritin in a man, that is the storage iron, is 322 in that range. That's the total ferritin in a man. Now, the total blood volume in a man is the fact that a man has 2 grams of iron circulating in the red blood cell in his circulation, a normal size man at any time, and 1.5 grams in the store as reflected as ferritin. That 1.5 gram represents a total of 6 units of blood, because each unit of blood has 250 milligrams of iron in it. Now, when somebody is bleeding, let's say from cancer of the stomach, or whatever the process is or processes that's starting the development of cancer of the stomach, automatically bleeding begins as well, very slowly. And the bleeding is intermittent. Now, if a patient is under your care, I'm giving an example of a man because it's easier. The woman is much more complicated. I'll get into that in a minute. Then suddenly you do a blood count on physical for whatever, the so-called annual physical, which basically doesn't exist much anymore because the HMOs don't pay for annual physical. So you just do routine blood count. Let's say the normal hematocrit in a man, let's say, is from 42 through 50. That's the normal hematocrit, which is the percentage of red blood cell as opposed to the red blood cell per million. Well, it comes back normal. Let's say it comes back 50. That's the upper normal limit of the hematocrit in the man is 50. The man looks fine. He has no symptom. But as part of that blood test, you also included a serum ferritin, okay? Which is the right thing to do. Because if you don't do it, you would have missed the boat. So the ferritin comes back, let's say for the sake of argument, it's 90. Because the ferritin is a range from 10 to 320 in a man, 320 to 320, depending on the laboratory. The hematocrit is perfectly fine. Patient is completely asymptomatic. You did a rectal exam. The stool had no blood in it when you tested it with Hemocolt. But everything is normal. You're about to shake the hand of the guy to say goodbye, see you next year in 6 months or whatever. But there's a problem. The ferritin is 90. It's abnormal. It is completely, totally abnormal. There is no reason on earth that a man who doesn't have PNH, which is something that you could urinate iron, and I'm not going there. He's not passing blood in his urine. If gross blood, he would have seen it with his eye. He's not vomiting blood. He's not coughing blood. He's not passing blood per rectum. Why is the ferritin 90? Where is the blood is being lost? In a man, you only have one place is being lost, in the stool, very slowly, intermittently. You can't just file the result away and say it's fine. Of course the hematocrit is 50, but that's the point. When you are bleeding very slowly, occultly, from your GI tract, no matter where it is, the first thing that's going to go become low is the ferritin. Because you must, by necessity, unless you're bleeding acutely, if you're bleeding chronically, you must use up the entire storage iron, all of it. You must use it completely. After you finish using it completely, by the way, while you're using it, you're losing it, you're also feeling, in some instances, you start feeling lousy as well. You're yawning, you're tired, you don't know why. You know why? Because the cytochrome system, which is located in the brain, requires iron to function, for us to process oxygen. Guess what? The iron that's in the cytochrome system is part of the storage iron. So now you know why people are walking around sometimes, men and women, feeling tired and yawning, sleepy, falling asleep on the desk, etc., or have insomnia or become irritated. All that time, anemia is not there yet, and yet this is happening. You know why? He or she has lost the iron that's in the cytochrome system in the brain, which is part of the storage iron. You cannot process oxygen properly. For us humans to function properly, be alert, for our brain to function properly without the cytochrome system be fully complemented with this storage of iron so that we could process oxygen. I know this is probably the first time you're hearing these things, because this is not a medical school and you're not a medical student or intern and resident. But those are the things that I'm taking the opportunity to let you know about. And I choose to do that. I'm not being paid to do it. I don't care. I'm not looking for, I'm doing that. That's what I choose to do. Okay, fine. So now that you understand some of this stuff, now, to make matters worse, the individual in question must now lose a third or more of the circulating iron in the red blood cells before anemia begins to set in. Look at how far. We're talking about anemia. That's why I'm taking the time to explain how long it will take. It's several years. 2, 3, 4 years it will take for all this to occur. Because the 1.5 gram of iron must be lost completely. And then a third or more of the 2 grams of iron that's in the circulation must be lost as well before anemia shows up when you do a blood count. So by the time you do the blood count and it comes back, there is anemia, and suddenly the doctor says, oh my God, you are anemic, I'm going to send you to the gastroenterologist, which is fine. That's the right thing to do. But if you go back 2, 3, 4 years back, look at the record, if there was ferritin there that were done, you would have seen the level was already abnormal. And that's the point. Because you don't have to be a genius to determine somebody has anemia. Okay? And now you have to evaluate it. There are ways of evaluating the anemia. And I'm not going to bore you besides just sending you to the but look, let me be a little bit more open about it. When you have the anemia, there are different types of anemia. So when you see the anemia, you have to do a reticulocyte count. If you do the reticulocyte count, the reticulocyte is the baby red blood cell. That allows you to categorize the anemia. That's right. So you don't have to spend a whole lot of time, a lot of money, throwing money away, or doing a whole bunch of expensive, unnecessary tests. If you just do the reticulocyte test right there, you see anemia, you do a reticulocyte count. Let me explain to you how it works. If you have anemia, your reticulocyte count is high. That means one thing and one thing only. You are hemolyzing. That is to say, you are breaking up red blood cells, and the body is trying to replete the store of red blood cell by dumping baby red blood cell into the circulation. Therefore, the reticulocyte count is high. You can't be hemolyzing without having elevated reticulocyte count. Okay? So that's one category. Okay? Now, if the reticulocyte count is normal, then it means, of course, you have anemia, but that's called normochromic normocytic anemia. You have a normal reticulocyte count. It could be, that means either, that could be you bleeding. You're losing it somewhere. If, on the other hand, your reticulocyte count is low, that's hypoplastic, meaning that your bone marrow is not capable of making red blood cell in a sufficient amount, period. You see that? So those three things allow you to know how to proceed. Hyperplastic, normoplastic, hypoplastic. That's the beauty and the value of doing the reticulocyte count at the time that you are looking for anemia. So when it comes back, you know exactly how to proceed. If you understand clinical medicine, and there are thousands of doctors there that understand it well, then you know how to proceed. You don't go and throw money away doing this test, that test, trying to like you're in the ocean and you lost your compass, you don't know which way to go. It doesn't work like that. So now you understand the value of the reticulocyte count, okay? It categorizes for you the type of anemia that you are dealing with. And different types of anemia requires different type of evaluation, which in turn require different, that you're doing different tests. So you don't then jump in a basket full of tests that are super expensive and you still don't know where you are. Okay. All right, so now that we get back to how low, we get back to the fellow who has low ferritin. Right away, the next step should be, it doesn't matter to me how high the hematocrit is, he goes to the gastroenterologist to find out where the blood is being lost, where the iron is being lost. Yeah, because you have to understand each cc of blood has 0.5 milligram of iron in it. So this is how you could very early, at the earliest possible time, pick up what's going on with the stomach. And that's the best chance of curing this cancer of the stomach. If you don't do that, by the time anemia shows up, the cancer has been there a long time. Yes. Because you can't just start having cancer today in the stomach and start vomiting a bucket of blood. It doesn't work like that. Okay. Now let's spend time talking about what we deal with in the female situation. Very complicated. Complicated because women menstruate. They started menstruating since they were little young ladies at age 10, 9, 11. And each menstrual cycle that is of a normal nature, 50 cc's of blood is lost. That means 25 cc's, 25 milligram of iron is lost. So it's not that difficult to calculate going back by asking how old were you when you begin to menstruate to calculate what the hematocrit should be. You could calculate how much is lost. If there are issues with menstruation, irregularity, other issues, fibroids, etc., you cannot calculate that because you really cannot calculate the volume of blood with the clot and all this other stuff. We understand that. In addition to that, if the lady has had children, very important, every pregnancy that a lady carries to term, she would have lost 750 milligram of iron. That's right. That's 3 units of blood. Okay, because each unit of blood has 250 milligram of iron in it. And the unit of blood is what you gave when you donate blood at the blood bank, okay? You say, well, what happened to that iron? Well, she wasn't bleeding it. It was the fetus that she's pregnant with that's sucking up that iron from the mother. It doesn't matter where the iron is, the fetus is going to have to suck it up to survive, to develop during the pregnancy. So you understand that. Now, that is why OBGYN doctors prescribe those prenatal vitamin that has iron in it. And the problem is there isn't enough iron. Prenatal vitamin, to the best that I recall, and I discuss it in this book, has probably 30 milligram, 35, 40, in that range, because I don't remember the exact number, but it's below 50. Let me tell you what that means. And I'm not criticizing, I'm just teaching. The human stomach, the way God created it, in order for you to replace iron that is missing in the body, you must, let me repeat that, you must present 180 milligram of elemental iron to the stomach in order for 1/3 of it to be absorbed. Let me repeat that. To see how bad things really are. This is the formula. And that formula has been known since medicine started practice several hundred years ago. Even the older hematologists came up with it, and it's correct to this day. You must present 180 milligram of elemental iron through the stomach so that you could absorb 1/3 of it. That is why each ferrous sulfate tablet has 60 milligram of iron. When the doctor tells you to take 3 per day, that's 3 times 60 is 180. That's the formula. Okay, in addition to that, nowadays, there are medications such as Ferrex Forte, which has come to my mind, that's why you take 1 a day. The doctor said take 1 a day because that one pill has a amount of iron that is necessary so that the stomach will allow you to absorb the 1/3. Now, I have no idea why folks don't know this stuff. It's none of my business that they don't know it. Unless you have hemochromatosis, primary hemochromatosis, which is a condition that forces you to overabsorb iron. When you give people iron treatment to replace iron loss, you're just darkening the stool. You're not treating them unless you follow that formula. Okay? Unless you follow that formula, okay? So, and that's the fact. That is the reason why they make medications like Chromogen, Ferric. That's how those are made once a day, because they have that a small exact quantity of iron in it so that you could absorb the 1/3. So when you have a pregnant lady who's losing iron like crazy because the fetus is sucking it away from her, and then you give her a little vitamin pill, prenatal vitamin, that has 30 milligram or something milligram, you give me a break. Are you replacing iron? You're joking. You're not replacing iron. This is not criticism. This is facts. This is scientific facts that has been documented and proven by people way before I even became doctor. You were just darkening the stool, but you were not replacing iron when it is needed the most. When it is needed, the mother needs the iron, the fetus needs the iron, and who are you to just put 30 milligram or 40 milligram of iron in the prevent, and you tell him you're treating this patient? Give me a break. You are not. You're just darkening the stool, or you do not understand. Then this patient needs the help of a hematologist who understands red blood cell and hemoglobin medicine so that they can explain it better to the patient. Is also if the lady is breastfeeding, you lose iron in the breast milk as well. So by knowing all these things, and you take proactive actions, you could early diagnose cancer of the stomach by realizing that the ferritin is going down. You try to explain it by referring the patient to the gastroenterologist. He or she will then do the scoping, and bingo, they find there's something in the stomach that's causing the blood loss, hence the iron loss. And then they can call the gastric surgeon, or for that matter, the GI doctor himself or herself might take that thing out, and then bingo, you solve the problem right there, and then you're preventing this thing from growing into a real cancer and save somebody's life. Listen, I'm stopping here until I see you again. This is Dr. Alcena saying so long and bye-bye.